and good evening, everyone. I hope you are having a wonderful day and are ready to find out a bit more on ICSI. And of course, we have a special guest with us tonight to talk a little bit about that. And this is Dr. Björn Heindryckx. And hi, how are you feeling tonight?
Yes, I'm fine. Good evening, everyone.
All right. Thank you so much for joining our Stronger Together initiative. It's definitely a pleasure to have you with us and supporting this initiative. And thank you also for confirming that you can hear us. And before we start with the presentation, let me just mention that, as you know, we are here every single day as we want to support you through those definitely strange times, but also we want to support you and give you the opportunity to ask your own questions, top fertility experts. As you know, lots of different topics we already had, and as you can see, another topic has been brought by Dr. Björn. So thank you so much for that. And well, before we start, I also want to mention that Stronger Together is an initiative that has been supported by lots of ambassadors and partners, and you can see them right here. So thank you so much for your constant assistance and support as well. And tonight's topic, as I mentioned, it's failed fertilization after ICSI and how can it be overcome. So this is the presentation that Dr. Björn Heindryckx has brought to us, and I just want to also mention that he is from Ghent Fertility and Stem Cell Team Department for Reproductive Medicine, which is in Belgium. So we do have another guest from different country. This is your first webinar with us. So thank you so much once again. And so, well, are you ready to start with your presentation?
Yes, thank you, Caroline, for this nice introduction. So I will discuss the topic of failed fertilization after ICSI. How can we overcome this when we have this result after ICSI? So just to introduce myself, I'm a Belgian. I was born in Bruges. I have two children myself, Leander and Gitte. I did engineering studies, that's my background. And I started since 1999 working in the field of assisted reproductive technology. First as a embryologist, but I switched over to research quite fast. I did my PhD. I defended it in 2006. It was about artificial gametes, but also about this topic of today, so assisted oocyte activation. So we have some experience in this topic already from a long time. And in 2014, I became professor also. So I also do a lot of teaching nowadays for students. But my main task is coordinator of the research that we are doing. So this slide shows an overview of the topics that we handle in our research group. So our research group is called the Ghent Fertility and Stem Cell Team. So our main focus is actually to focus on patients that are difficult to treat. What I mean is, yeah, patients that we don't have available methods very ready for them. So it's patients that, yeah, that is a challenge for or us as professional in the field. So for example, we do stem cell research, and that's for patients who don't have any oocytes or sperm. So that's, of course, a very challenging group that we can still not overcome yet. But the other of our research is more clinical translational research, so it's more getting into the clinic. So one of the topics is this failed fertilization, which I will explain today. But other topics we are also dealing with, such as mitochondrial diseases, which is a very hot topic in our field of ART, failed implantation, Also, we do a lot of genetic screening, so pre-implantation genetic diagnosis using this next generation sequencing, and also some fertility preservation. And since 2 years, we also started gene editing, so trying to correct some mutations which are related to infertility. I will explain you in one of the last slides in the context of this topic of today. So this slide shows an overview of the topics that I will discuss during the presentation. So first of all, I will explain a little bit background of what is fertilization, how it works. So fertilization goes together with oocyte activation. So I will try to explain it in a simple way. Both the sperm and the oocyte play a role in this fertilization process. Then I will explain you what we do when we have failed fertilization after ICSI. So we developed some tests to see if it's sperm or oocyte caused. And then I will show you how we overcome it. So we can overcome failed fertilization after ICSI quite successfully. And then I will end with some interesting cases, so some interesting patients that we had lately, and just some 1 or 2 slides about our future research on this topic. So without going into detail, of course, because this is patient-focused, this webinar, but we have to realize that when the sperm gets into the egg, there are some things happening with the sperm that are normally happening when you do normal in vivo fertilization, so when there is no assisted reproductive technology, or when there is IVF. So for example, the capacitation of the sperm happens during normal fertilization in vivo or during IVF. And why I say this, it's important to realize that when you do ICSI, you bypass a little bit these processes. So the sperm, if you do IVF, you have the sperm has to go through the cumulus cells. That cumulus cells are the feeding cells around the oocyte. The sperm has to bind to the zona pellucida, so the egg shell around the oocyte. The sperm and the oocyte membranes will fuse. So all these processes are happening during IVF and during natural fertilization, but they are not happening during ICSI, and that's something important to keep in mind. But of course, the rest of the processes, ICSI, you just inject one sperm directly into the oocyte. These processes of oocyte activation, sperm processing, and fertilization, so pronuclear formation, they also happen in ICSI. But it's difficult, it's important to keep in mind that when you do ICSI, you bypass these 3 first processes. So what is fertilization? So fertilization is the start of, it goes together with the start of oocyte activation. So before you have successful fertilization, you need to have oocyte activation. And how does it work, oocyte activation? Well, when the sperm enters the oocyte through ICSI or through IVF, there is a protein present in, so this is a sperm here, depicted here. So when the sperm gets into the oocyte, the content of the sperm head gets released into the oocyte, in the cytoplasma of the oocyte. And there is one important factor, PLC Zeta. It's short for phospholipase C zeta. So it's a protein, an enzyme, which produces IP3. I will not go into detail all these names. That's not so important for you to remember. But the IP3 will bind to the receptor, the IP3 receptor, which is the oocyte factor. So, and this IP3 receptor, these receptors contain calcium. So the protein, the PLC Zeta, will provoke calcium oscillations. And that's something that has to happen. If this is not happening, this calcium oscillation, so calcium transients, it's several calcium oscillations during a certain time. If these oscillations are not happening, you will not have successful fertilization. So that's the first sign of fertilization. It's these calcium oscillations that need to happen, and they are triggered by this sperm protein, which is called PLC Zeta, and the PLC Zeta induces the calcium release from the receptor in the oocyte. So this calcium oscillation, so they are really crucial for fertilization. But also they are, well, there are some data that show in literature that a correct calcium pattern also influences embryo development. We still are not sure if this is also the case in human, but in animal, we know that this specific calcium pattern will also influence correct embryo development. Let's go to the next slide. Well, this is very biochemical slide, which I will not go into detail, but I just want to show it because next to these calcium oscillations, a lot of processes are happening in the oocytes. So you have a lot of proteins that are present in the oocyte, and they all have to do their own thing. So why I show you this is that, yeah, you first need the calcium oscillations, but downstream, so beyond the calcium oscillations, a lot of things need to happen before you have successful fertilization. So I just want to show this because it can go wrong here, that you, for example, don't have any calcium rises, but also downstream it can go wrong. So if these proteins are not functional within the oocyte, you also will not have successful fertilization. Well, this slide I already explained. So in mouse and then also in other animal models, they have shown in literature that this correct calcium pattern is not only necessary for successful fertilization, but it might also affect embryonic development and even your pregnancy chance. But in human, we still don't know if this is the case or not. So the role of the sperm versus the oocyte. So I already told you this PLC zeta, that's the sperm factor that triggers the calcium oscillations. It took a long time before we knew which factor is causing these calcium oscillations. So in 2002 in UK, it was identified that the PLC zeta is the sperm factor. And yeah, when we for the first time found a mutation in the PLC Zeta gene, we could be sure that this PLC Zeta is really crucial for fertilization. So in 2009, we identified in a patient that had failed fertilization after ICSI, we identified a mutation in the PLC gene. So from there on, we were quite sure that this PLC Zeta, because there was a mutation and the protein was not there, that it's really the sperm factor responsible for this calcium oscillations. Yeah, so it can go wrong in the PLC Zeta. There can be mutations in the gene that give rise to abnormal PLC protein, so that the PLC protein is absent or abnormal localization in the sperm, and so on. So if there is a mutation present in the PLC Zeta, it will result in a failure of oocyte activation, so in a failure of fertilization. We still don't know if it's the only sperm factor. There are some research going on to see if this is the only sperm factor responsible for fertilization, but we still don't know yet. And also together with the UK group of John Parrington, who is one of the pioneers in the fertilization process, they made a knockout PLC mouse models. So they knocked out the PLC gene, and indeed we see that if the PLC is absent, you don't see any calcium oscillations and you don't have any fertilization. The story is not complete. Well, this is going into detail, but the funny thing is that when we do IVF with this PLC Zeta or natural fertilization, we do see some fertilization. So that's why it's important to keep in mind that when you do ICSI, we don't see any oscillations, but when we do IVF or in vivo mating, we do see some fertilization. So that's important to realize that IVF and ICSI are different things that we should take into account. Yeah, the role of the oocyte, we know that there are a lot of proteins present that need to work downstream, so it can go wrong in one of these proteins, but there is still very few evidence or research has done about this. But what is sure that, the oocyte, this IP3 receptor, is responsible for the calcium oscillations. So if there is something wrong in this receptor, there will be no calcium rises caused by the oocyte. This is, not, I will not mention a lot, but if you have an immature oocyte and you inject a sperm into an immature oocyte, we see that the calcium release is not very big yet. It's only during the final stage of maturation that when you inject the sperm into a very mature oocyte, that you see a normal calcium pattern. So it's important to have a very mature oocyte for successful fertilization, for successful oocyte activation. So how do we cope with failed fertilization? So what does it mean, failed fertilization? Well, we normally check fertilization the next day after we do ICSI. And normally we should see after 16 hours or 18 hours after ICSI, we should see 2 pronuclei. So 1 male pronuclei and 1 female pronuclei and an extrusion of the second polar body. So this is a normally fertilized egg. But when it's failed fertilization, we only see the mature oocyte without any pronuclei or any second polar body. So that's a failed fertilized oocyte. But yeah, luckily it doesn't happen much. So ICSI is very efficient. It normally gives rise to an average fertilization rate of 75%, which means of the 10 eggs you inject, you will have 7 to 8 normally fertilized. But still, there are some patients that everything is not fertilized. So in up to 5% of all ICSI cycles, we have this phenomenon of failed fertilization. And then it's always, when we see this failed fertilization, the doctor calls the lab and he asks what has gone wrong in the lab. And the embryologists, they think, well, maybe it's due to the doctor. They give a bad stimulation to the patient. So it's always, a two direction when we have this unfortunate failed fertilization. But what is the main reason? We know from research, if you have, of course, a sufficient number of normal oocytes. If you only have 1 oocyte from a patient, you can have easily failed fertilization. But if you have a decent number of oocytes and you have motile sperm, because immotile sperm can also induce failed fertilization, we know that it's mainly due to this failure of oocyte activation. So again, this PLC Zeta, it produces IP3 and it binds to its receptor from the oocyte and it will induce these calcium peaks. So why do we want to know if we see failed fertilization, if it's sperm or oocyte related? Well, we feel that, we know this, that couples like to know it, if it's sperm or oocyte caused. It's of course a very stressful event if you have failed fertilization. We don't want this, of course. And it's also important, because first of all, the patient wants to know. And also, yeah, if we do this treatment, which I will explain in the next slides, we know that if it's sperm related, the efficiency will be better. So it's a little bit ironically, but we know that if it's sperm related, we will have a better success when we do this special treatment of artificial oocyte activation. And on the other hand, if it's not working, the assisted oocyte activation, this treatment, yeah, we have to send the couple to oocyte donation or sperm donation. So for that reason, it's also very important that we know if it's sperm or oocyte caused. And a third reason is that, yeah, there could be a mutation present in the oocyte or in the sperm. So it's better that we counsel the patients, that we know if there is a mutation, that we warn the patients that even if we can overcome it, that if they have in the future a boy or a girl, they might also have this problem of failed fertilization. So that's why we find it important to do diagnostic test to distinct sperm from oocyte. So in our lab, we do this mouse oocyte activation test for all the patients that have failed fertilization. We also optimized the mouse oocyte activation test with some other techniques of calcium analysis, but that's not so relevant for this talk. We only do it for some patients, this calcium analysis. In the UK, they do immunostaining, so they stain the PLC Zeta in the sperm, but we don't find it very useful, so we don't do it. We do a lot of genetic screening, so we check if there are mutations present in this PLC Zeta. That's one of our research topics. And indeed, yeah, we find the first mutation in 2009 in a patient that had failed fertilization after ICSI in 2009. And when we inject this mutated sperm, we don't see any oscillations mostly, or only one calcium rise, which will not be enough to activate or to fertilize an oocytes, or very small calcium peaks, and these will all not be enough to activate a human oocyte. Compared to control sperm with normal fertilization capacity, you see a lot of peaks with a high amplitude. So yeah, we are doing genetic screening and we find more and more mutations in the PLC Zeta. So yeah, we get more knowledge. So that's why it's important to get to do this genetic screening. And we see more and more mutations in the PLC Zeta of patients that experience failed fertilization. So how does this MOA test work? So we collect sperm from the patient, human sperm, and we inject it into mouse oocytes. Yeah, ideally we should do it in human oocytes, but we don't have thousands of human oocytes to do research on. So that's why we use mouse oocytes, and human sperm can activate mouse oocytes. And then we check how many of the mouse oocytes of the patients were activated. We check two cell formation because the PN formation is late at night, during midnight. So we check the next day and we see the two cell formation. So that's the activation rate. So, and then we classify our patients in three groups. So in the MOAT group 1, it means that less than 20% of the mouse oocytes were activated. So that's definitely a sperm problem because most of the sperm cannot activate even a mouse oocyte. If then we have an intermediate group, MOAT group 2. Until recently, we were not sure if this was sperm or oocyte related because, yeah, some sperm can activate a mouse oocyte, but some sperm cannot. But after doing this calcium analysis, we now know that this MOAT group 2 is also a sperm problem. And then we have a normal MOAT result, MOAT group 3, with all the sperm capable of activating a mouse oocyte. And in this MOAT group 3, we suspect it's an oocyte problem because the sperm is able to activate mouse oocytes. So yeah, again, this mouse oocyte activation test, we inject human sperm into mouse oocytes and we check how many are activated. So again, so the MOAT group 1, we are sure it's sperm related. So the sperm, the PLC Zeta is the problem. In this MOAT group 2, when there is a diminished oocyte activation capacity, we now know for sure it's also a sperm problem. So from the moment we have a little bit reduced MOAT result, we know for sure it's sperm related. And then we have our group 3, that there is a normal activation capacity, and we suspect it's an oocyte problem. Okay, yeah. For example, we have this specific group of patients that have Globozoospermia. So normally a sperm head has an oval head with a nucleus and an acrosome. And this Globozoospermia, they miss the acrosome. But the PLC Zeta is located in the acrosome, so they also miss the PLC Zeta. So this Globozoospermia can never fertilize an egg naturally or through ICSI. So we have to overcome this. So that's really an example of a sperm problem. This slide shows an overview of the MOAT tests that we have done until 2016. So most patients, 40% of the patients go into the sperm problem. So 10% in the MOAT 1 group and around 30% in the MOAT group 2. So let's say 40% has a sperm problem. And in 60% of the cases, we identified an oocyte-related problem. I will skip this calcium analysis because it's maybe too it's too expert explanation, and it doesn't matter for this talk. So how can we overcome this failed fertilization? So we do this treatment of assisted oocyte activation. Yeah, you can artificially activate an oocyte and you can induce a single calcium rise, or you can induce several calcium rises in the oocyte. So there are different products that do this. People have used a lot of products to activate mouse or human oocytes, but we use this ionomycin because it's a very powerful product to induce a big calcium peak in the oocytes. In the UK and in a lot of European countries, they use another product called calcimycin, but in our hands, this one is not working efficiently. So there are different products with different efficiency. For example, some people use strontium to activate oocytes to overcome fertilization failure. But in our hands, it doesn't work. We have published on this strontium use. And if we expose oocytes, for example, 10 oocytes to this strontium, we don't see any fertilization happening. So we wonder how these publications can rescue failed fertilization with this strontium because it's not working in our hands. We don't see any calcium oscillations when we expose the oocytes to strontium, for example. So what are we doing in our hospital? So together with sperm, we inject an amount of calcium. I will show it in the video that is coming. And we expose the oocytes 2 times to this product, ionomycin. And it's actually, we do mimic 3 calcium rises. So the first one due to the calcium injection together with the sperm, and then a second peak and a third peak caused by this exposure to this product of ionomycin. If I'm correct now, Caroline will play this movie where I will show you the technique of this assisted oocyte activation. So it's actually ICSI, but something extra. So we first pick up a sperm, here in our needle. So we pick it up in our needle, sperm is in the needle, so that's the normal ICSI technique, and normally we now inject it into an oocyte. But for this assisted oocyte activation, we first take up an amount of calcium inside the needle. So now there is calcium in the needle, and then we do normal ICSI. We go to the oocytes. Here you have the oocytes. And then we will inject the calcium solution together with the sperm inside the oocytes to have this first big calcium peak to enable successful fertilization. So we fix it to a holding, and then we pierce through the zona. 1 second. Yeah, where is the sperm? Yeah, the sperm is coming. So first, yeah, we aspirate. Oh, it went back. The video went back, at least on my screen. Let's see if it now goes to the end. So it's the normal ICSI technique, but you inject an amount of calcium which is present inside the needle. So the sperm is coming. Yeah, so now we inject the calcium together with the sperm. And we wait a little bit until the sperm attaches, and then we gently remove the needle, and now the sperm together with the calcium is inside the oocyte, and we hope for successful fertilization. Can I see the slides again, Caroline? Yes, thank you. So this assisted oocyte activation, we did the first study in 2008 already. So we treated 30 patients with this assisted oocyte activation. And before, with normal ICSI, the fertilization rate in these 30 couples was 14%. So that's much lower than the average 70%. No pregnancy in 50 cycles occurred. So when we applied this assisted oocyte activation, we can restore the fertilization rate up to 75%, so very normal, and also a very satisfactory pregnancy rate of 33%. So this was already 2008, and we have now updated our results. So instead of 30 patients, we now have described 122 patients. So 19 were belonging to the MOAT group 1, so a sperm factor, 56 to the MOAT group 2, so also a sperm factor, and 47 to the MOAT group 3. So if we look at the efficiency, we see that the fertilization is still very high. So in the MOAT group 1, we can increase the fertilization rate from 10% with normal ICSI to 70%, which is very normal after assisted oocyte activation. And also the pregnancy rate, when we do normal ICSI, it was 0. And when we did this assisted oocyte activation, it went up very high, even close to 50%, which is, yeah, very high success rate, at least in the MOAT group 1. Also in this MOAT group 2, we can increase the fertilization rate up to 63%, and also the pregnancy rate from 7% to 35%, which are normal rates of success. In the MOAT group 3, where we suspect an oocyte factor, we do see that the fertilization rate is not so high after AOA. So it's 57% instead of after normal ICSI 18%, so it's still significantly higher. And also the pregnancy rate is significantly higher, so up to 29%. So even in oocyte factors, it's efficient, but a little bit less efficient than when there is a sperm problem. Okay, go to the next slide. So a lot of UK clinics and also other European IVF labs, they use a commercial activating medium, which is called cold active. And we have done a study in 2015, but we see that this cold active in human oocytes, it doesn't create a very high peak. So the orange ones are the oocytes exposed to this cold active. And we see that the calcium release is very low actually. When we compare it to ionomycin, what we are using, these blue lines, we see that it's a lot of calcium release. So yeah, we are not using this commercial cold active medium, and yeah, I get some requests or questions sometimes from UK IVF labs or some other IVF labs that they say it's not working, the assisted dose activation, and then they explain they use this cold active, but yeah, in our hands it's not working because yeah, there is no slide about this. When we expose oocytes to cold active, we don't see any fertilization happening. So it really matters which product you're using during oocyte activation. So I will end up with some interesting cases. Well, the first patient, the first couple, she was a 35-year-old woman, so still young in reproductive age. But she had a history of molar pregnancies. So molar pregnancies means that the oocyte was fertilized naturally by two sperm, these partial molars. And of course, you get an abnormal chromosomal abnormal embryo because it's two sperm fertilizing one oocyte in a natural. So they end up with miscarriages or they cannot go to full term, of course. So yeah, we did ICSI with this couple. Yeah, of course, to avoid dyspermic fertilization with two sperm. In ICSI, you only inject one sperm, but she still. What was surprising after ICSI with one sperm, no fertilization happened after ICSI. So we did some testing. The MOAT was normal, but we saw in calcium pattern analysis that the calcium patterns were abnormal, and we found indeed a mutation in this PLC Zeta. And then after assisted oocyte activation, we could restore the fertilization, and she obtained 4 children after AOA. So in this couple, and we had several other couples with this problem of partial moles, it seems to be that two sperm they contain enough of this PLC Zeta to activate the egg, but of course resulting in an abnormal chromosomal embryo and an abnormal pregnancy, which will lead to miscarriage. So one sperm does not contain enough PLC Zeta to induce a pregnancy. So we had a couple of similar cases recently. And the second case I want to present is a female, 39 years old. She came from abroad also. She had a history of low to failed fertilization in another center. So she had undergone 3 times IVF with very low fertilization rates. 2 on 6 oocytes fertilized, 2 on 6 oocytes fertilized, 1 on 8. But still, she had some fertilization after IVF. And when she did ICSI in another center, nothing fertilized. So they came to our center because they had low fertilization, abnormal low fertilization or failed fertilization. We did all the testing and everything proved to be normal. So, but we still, yeah, we were suspecting an oocyte factor. So we did AOA, but still we got failed fertilization even after this assisted oocyte activation. And then, yeah, we discussed and we said, yeah, they had some fertilization after IVF. So why would we not try in the next cycle to do half IVF because she had some fertilization in the past and half again ICSI with AOA. And yeah, indeed, very surprisingly, IVF, it worked. So 4 of the oocytes fertilized, so all fertilized, and she had good embryo development, but unfortunately no pregnancy. And when we did ICSI on the other half of the oocyte, it was again failed fertilization. So that's why I said in the beginning that we have to realize difference between IVF and ICSI. So sometimes for some couples, we don't have to use any fancy technique as this assisted oocyte activation, but we should rather think to go one step back and, for example, do IVF. This will not help for all the couples, but it's an interesting case that we should consider also maybe for other couples. Yeah, we do have high success rates with this assisted oocyte activation, but not for all the couples. Yeah, if I would say it in percentage, of all the couples that we treat, 90% will be successful. They will have fertilization, they will have embryo development, and they will have a chance to pregnancy. But still, in less than 10%, AOA does not lead to fertilization. So it means that because we artificially induce this calcium rises, it means that it's something downstream, something goes wrong. And yeah, we know that a lot of proteins in the oocytes have to be functional. So it can go wrong in one of these proteins that we still don't know. So that there are mutations present in these genes that should make these proteins. And if something goes wrong there, we cannot help the couple and we have to go to oocyte donation at the moment. We are starting up a study and we did already some experiments because, yeah, we want to apply this nuclear transfer in the future. We are quite convinced that if there is a problem in the proteins in the cytoplasma, which are in the cytoplasma, that this nuclear transfer could overcome maybe the problem. So the principle is then that you take out the nucleus of a diseased oocyte or a low quality oocyte and you bring it into an egg from a donor where you first remove the nucleus, the DNA from the egg donor. So you have reconstructed a new oocyte containing the nucleus, so the genetic information from the patient, and with all the good cytoplasma, with all the good proteins. So we are quite sure that in these cases where there is an oocyte problem, that this technique might be useful in the future. So we are doing a lot of research now on this topic. And we tried it already on a couple who had failed fertilization after ICSI with AOA. So we did this spindle transfer. We removed the nucleus and put it in an oocyte from another patient. And remarkably, yeah, we could achieve fertilization for the first time in this couple. It's still in research context. We cannot transfer these embryos because we are not allowed to transfer them back. But we will start up a new study to get more evidence that this nuclear transfer technique might help for some oocyte cases. And yeah, another topic that we are doing research on, because yeah, by applying this technique of assisted oocyte activation, we know that there are some patients having, for example, a mutation in this PLC Zeta. We can overcome it efficiently with assisted oocyte activation, but we know that, for example, if boys get born, they will inherit this mutation and they will also have problems to reproduce in the future. So that's why we investigate if we can use this CRISPR-Cas. Maybe you heard of it. It's a tool to modify the DNA. So we are doing research to see if we can correct the mutation and that we can give to eventually, because this is of course still in research context, that we can eventually produce boys which will not have to deal with infertility. So that's one of the research topics that we investigate. So I will end up here. So we think it's very important to distinguish between sperm and oocytes for different reasons. Genetic screening should be done, what we also do, to warn the patients also if they have children in the future with this AOA, that they might inherit also the infertility condition. But in general, we can say that this assisted oocyte activation, so inducing this calcium rises, is very efficient and it can overcome failed fertilization after ICSI in most of the patients. So let's say in more than 90% of the patients, but using the right protocol. So there are several protocols being used by several clinics, but well, I always like to stay modest, but I think we have really with this ionomycin a very powerful product to induce efficient fertilization. And of course, future research is necessary and ongoing in our department. So I would like to thank you for your attention. And of course, I want to thank all the members of our research team which are involved in this research. Yeah, there are two clinical doctors, two gynecologists, Professor Dominic Stoop and Dr. Frauke van der Meerschoot, who are really experts in this topic of failed fertilization after ICSI. And they mostly counsel the patients because I'm not a medical doctor, I'm a research embryologist. So the patients, of course, have to go to a doctor to discuss the problems that they are dealing with. So I thank you for your attention, and I'm ready if there are any questions to answer, if I can answer the questions at least. Thank you. Uh, Caroline, I just want to mention the sound is very bad. I cannot understand you at the moment. Yeah, now it's yes.
Thank you so much. And well, as you can see, there are some questions, but of course, I want to remind everyone that if you have any questions you would like to ask, this is your time. So go ahead, type those in, and Dr. Björn will be happy to help you out, I'm sure. So let's have a look at the very first question that we got. When would you recommend ICSI, or is it always indicated?
Well, it's of course depending on the sperm quality. Yeah? So we have some minimum parameters that the motility should be at least so much percentage. The concentration should be at least so many millions. So yeah, we have criteria that almost every IVF clinic is using. And if a sperm sample does not meet the minimum criteria, we will do ICSI in the first cycle. So, but yeah, nowadays ICSI is a little bit overused. Also, well, of course, sperm quality has decreased during the last decades. The sperm quality has decreased. That's for sure. Um, the reasons for this, yeah, most people say it's environment related or the lifestyle of the patients, but we know it's a fact that sperm quality has decreased immensely during the last decades. So we are using a lot of ICSI. So for example, in Belgium, 70 to 80% of all the cycles use ICSI, and only 20 to maximum 30% use IVF. So yeah, it's because the sperm quality is not good enough to be sure that IVF will work. So, and that's why we prefer to do ICSI in the first cycle, to prevent that it will be fertilization failure after IVF because of too bad sperm quality. So we just, yeah, we have our criteria that everyone is using in all the IVF labs worldwide. And then we decide if it's IVF or ICSI, depending on the sperm quality. But yeah, we might overuse a little bit too much the ICSI technology. So I'm quite sure that in a lot of ICSI cases where the sperm is like on the edge of being good enough for, not good enough for IVF, but it's on the edge of yeah, the reference, that if we would do IVF with this couple, that it would also work. But yeah, we try to avoid, of course, failed fertilization after IVF. So that's why we quicker step over to doing ICSI.
All right, understood perfectly. Thank you so much for your very first question and for your thorough answer to this one. And this is definitely good to know as well. Okay, let's have a look. There is another question. Are there any other lab techniques apart from ICSI that can help with fertilization? I had a failure each time.
No, no. Well, if if no fertilization happens after ICSI, it's mostly due to this oocyte activation problem. So what we then do is this artificially induced calcium rises, and in the majority of the patients it works. It's only yeah, in less than 10% of the oocytes that we still don't have fertilization yet. There is no other technique at the moment to perform next to ICSI, because that's the last resort technique that is now existing. But yeah, if it's an oocyte problem, we are quite sure that we could maybe rescue it with this nuclear transfer technology. But it's too premature to use it now in the clinic. We still have to do a lot more experiments and research to know if this nuclear transfer technique would be the next step after ICSI to overcome some fertilization problems. But it will only help, of course, if it's an oocyte problem, because we are transferring the nucleus from a bad quality oocyte to a donor oocyte, and then we have to fertilize it with sperm. So it would only be beneficial for patients with an oocyte problem. But yeah, in most cases, when we identify a sperm problem, this assisted oocyte activation always works. And that's a fact. And it's working very efficiently. So, yeah, I don't know if they always had a failure, if this couple has undergone assisted oocyte activation. But when you use the right protocol, it should work in 90% of the cases that have dealt with oocyte fertilization problems.
All right. Again, thank you so much. And actually, there is a follow-up, okay, here from Laura. So let me go straight to this one. So I have 3 fertilized embryos. So would you go for blastocyst transfer or transfer day 2 or 3?
Yes, well, in our clinic, we shifted totally to day 5 transfer, and our success rates have dramatically improved since we use already for 6 years this day 5 transfer strategy. I would definitely go to day 5 because, well, when the embryos don't make it in vitro to day 5, they will very probably don't make it also in vivo. So it's a good natural selection when you culture your embryos to day 5, because, like I say, if they don't develop in vitro to day 5, very likely they will not make it also in vivo. So yeah, and also it's good to know for yourself if your embryos can make it to day 5, because, for example, we know in human embryology that the first 3 days of development are very much directed from the oocyte. So the oocyte has all the proteins present in the oocyte that ensure embryo development until day 3. It's only from day 3 onwards that the embryo awakes, that new proteins are produced by the embryo itself. So it's also good if you culture until day 5, that you know that the last 2 days, so from day 3 to day 5, that they are working. Because if they are not working from day 3 to day 5, if you have failed blastocyst development, failed embryo development to day 5, we suspect that there is something wrong rather with the paternal DNA, so with the father. Because, like I say, the first 3 days in human embryo development are exclusively directed through by the oocytes, by proteins already present in the oocyte. And from day 3 to day 5, it's both the maternal and the paternal DNA that has to produce or direct embryo development. So it's also good to know if they can make it at least to day 5 to think of paternal or maternal contribution. So in our clinic, we only do day 5 transfers nowadays.
And once again, huge thanks for explaining this to us as well. And next question again from Laura. Okay, so what about Pixie? When is it recommended?
Yeah, Pixie, well, it's a kind of selection technology to select sperm with normal DNA without DNA fragmentation. But I'm not a believer in the technique. Um, yeah, the studies that have been published are not convincing to me, and also not to the experts in the field, because when it would be promising, everyone would do Pixie. And well, I don't see a lot of publications anymore on this Pixie outcome. So I think it was a hype for a certain time that people thought that if you select sperm which are have contain less DNA fragmentation, that you have a higher success rate on a pregnancy. But all the studies that have been published are not reassuring, not convincing. So we also did some study on this Pixie, and yeah, we didn't see any benefit of using this technology. So I would not recommend it. I think, well, the literature is now quite sure that it doesn't give any benefit for any indication of any sperm abnormality.
All right, again, thank you so much for that. Well, Laura has added one more thing. Okay, so let's have a look. Do you use Max? Sperm Slow. The clinics I looked at don't do Max. I'm sorry if you mentioned this already. I wasn't listening to the whole presentation.
Ah, you were not listening. No, no, I'm just joking. No, we don't do this max um, in our clinic or sperm slow. And I don't, well, I follow the literature quite well in ART. So I didn't see any convincing literature again that this technique would help in improving fertilization rate, in improving embryonic developmental rate, or improving pregnancy rate. So I think, yeah, there are a lot of things coming up in the market now and then. So you have this Pixie, you have this IMSI that you select sperm with high magnification. You have this magnetic sorting of sperm, but they all disappear quite fast. So at the moment, there is no better technique than just routine ICSI, or in this case, when you have failed fertilization, you can rescue it, of course, efficiently with assisted oocyte activation. But all the other techniques that came into the market or are now sometimes being advertised as the miracle, there is no convincing evidence that something works very magically. So I would not recommend it. We are not using it. And also in literature, there is no concrete evidence that this would be a magic solution for anything.
All right, again, thank you so much for explaining. And well, I just want you to see that Laura wanted to thank you for the explanation about Pixie, and she is sorry she had an emergency.
No,
She
that's
was,
okay. I was just joking. I hope the cat
sure.
is okay.
Yes, okay, thank you so much. And yeah, she has also added a comment. Thank you for the honest answer. I just want to make sure I'm not paying for anything that is
Yeah,
useful, of course.
yeah, that's also important because yeah, a lot of these techniques are now advertised and
Hmm.
a little bit overpriced and sold to patients as a miracle, but no, don't do it, I would say.
All right, of course. Perfect. Thank you so much. And actually, now we will go to a kind of a different topic here about PRP. What is your opinion on trying to improve egg quality? And do you have PRP?
No, we don't use it in our clinic. It's a technique to increase the maturation status of the oocyte. What we do, what we do when we have this failed fertilization after ICSI, and we see that the MOAT, the mouse tests, points to an oocyte factor, what we do in our clinic is to wait longer to do the ICSI with the assisted oocyte activation, because we know that the maturation stage of the oocyte is very crucial. So if we suspect an oocyte factor, the cytoplasma can be a little bit too immature. So what we do in our clinic is that we wait very long time to remove the cumulus cells around the oocyte so that the oocyte is really getting matured after collection even longer than what we normally do in other normal patients. And also when we then denude the oocytes, we also wait an extra time before we do this assisted oocyte activation. So it might not be a bad idea to start up a study to increase the maturation uh, stage of the oocyte, but we don't do it in our clinic, and we haven't done a study, and it has not been done in the study of in the context of failed fertilization. But yeah, it might be a good suggestion to dig into further. But as I say, what we do in our clinic is that we plan all the AOA cases as pickup as the first. So the couple is put first on the planning. The egg retrieval, so like 7:30 we start. We put the AOA cases very early, 7:30, and then we wait a little bit longer than we do for the normal ICSI patients, just to get these oocytes very mature, because if they are very mature, they will respond better to this assisted oocyte activation. But it's a good suggestion from the the person that asked it, but we don't do it, and we haven't done a study yet.
All right. Perfect. Thank you again for the explanation. And of course, let's have a look. Okay, there are some three questions left. We will be slowly finishing. However, if you have any left, of course, go ahead and type those in. Okay, next question is from Belinda. Please, can I double check is what you have explained the same as calcium ionophore? I have seen this listed in my clinic's price list.
Please, can I double check is what you have explained not the same as calcium ionophore? Well, so to clarify this, I don't fully understand the question, but there are different calcium ionophores that are being used as a technique to induce these calcium rises. So in UK, as far as I know, they are only allowed to use this commercial one. It's called this Code Active. Well, the product in the Code Active is called calcimicin. And UK's, yeah, because of the regulations in UK, they can only use this commercial one, which is EU approved. But in our hands, it's not working. When we expose oocytes to this calcium ionophore that is used in the UK, we don't see any activation happening. And we only see, like I showed you on the picture, a very small calcium rise, which is not enough to activate an oocyte. So yeah, I'm not in favor of this calcium, for this commercial one. And I know the company is shifting. They will start in the near future also to produce this commercial one, the calcium ionophore that we are using, so the ionomycin, which is much more powerful, which gives a very big calcium rise, and which is very efficient in our hands. And well, I heard, but it's already 2 or 3 years that the company is doing this. Well, since we published our study and showed that this code active is not very efficient and not activating human oocytes in our hands, yeah, the company has developed a commercial version of the ionomycin that we are using, but it's still not on the market, unfortunately. But like in Belgium, all the labs use ionomycin. They all use our protocol to induce efficient calcium rises to overcome failed fertilization.
Okay, perfect. And thank you for this explanation. And let's have a look. Okay, sorry, there is a follow-up from Belinda, so let me go straight to this one. Okay, so if you say the UK only uses commercial, then really not worth me adding it.
Yeah, well, it gives some calcium rise, like we have seen in our study, but yeah, in our hands, it doesn't activate the oocyte, it doesn't fertilize the oocyte. I think it has to do with stability of the product. So maybe because some publications they mention that they can rescue failed fertilization with this code active, but the efficiency rate is always very much lower than our efficiency rate. But I think it has to do with stability of the product. So if you use it quite freshly, so it's you have to keep it in the refrigerator, this commercial one, and it's ready to use. So I think if you buy it and you immediately use it, it has still some power to work efficiently. But yeah, we used it after several weeks in the refrigerator. Like yeah, it doesn't expire so fast, so you can use it whenever you want. And yeah, we didn't see any activation, any fertilization with this product. So I think, yeah, it has to do with stability of the product. So it might work if you use it very freshly. And that's why some clinics get some activation and success, but to lesser efficiency as the protocol that we are using. So I heard a lot of complaints about this commercial called active, and a lot of labs, contacted us to ask why this code active is not working, but in our hands it's also not working. We didn't do a big study yet, for example, to study when it expires or when the activity is losing its effect. But I think it has to do with stability of the ready-to-use product, because the inomycin that we are using, we make it freshly for each patient. So we make it just before the treatments. We make the solution and we apply it uh, on a day for one patient, and then we throw it away. So we make it fresh for every patient that has to undergo AOA, because the ionophores we know are very unstable. So if you keep it for a long time, it will lose its activity and it will lose its efficiency. So I would not recommend to use this commercial code active that is used in UK.
And excellent. Again, thank you indeed for that comment and for adding that additional information on this. It's definitely interesting and something to remember. That's for sure. Okay, there are like two questions left, and we will be finishing. And the question is: so can sometimes happen that not all these sperm chosen for ICSI is correct?
Yes, that's something. Yeah, we always use motile sperm to inject. So because yeah, it's a sign that the sperm is alive. Of course, you should never select immotile sperm, because if it's immotile, it can be dead already for a long time, and then you have DNA degradation, which will affect your embryonic developmental potential. Yeah, we have to base on the morphology, the head. If there are no gross abnormalities that we see, but yeah, we cannot see the DNA inside. So it could be that the DNA is more damaged in one sperm than the other. But yeah, there are no techniques to examine this or no selection procedures like this magnetic sorting that can help to increase the efficiency of selecting sperm. So yeah, because yeah, embryo development, not all the embryos that we produce make it to day 5, so make it to blastocyst. So it could be that yeah, some sperm is not capable of supporting embryo development, and then it's the wrong sperm. But we cannot avoid. There are no techniques or microscopes at the moment to really choose the perfect sperm. That's not possible. So it could be that we select some sperm that is not correct.
Wonderful. Again, thank you so much. for this. And let's have a look. This will be our final question for tonight. So let's go ahead with this. When you are preparing for IVF, is there any food that is required for the couple?
Yes, it's a good question. It's a little bit out of my expertise field, but I know there is a lot now going on with nutrition and antioxidants for sperm quality and other stuff. Um, but for me, there is no concrete evidence that there is something magic to improve your sperm or egg quality. Because if there would be, then we would recommend it for every patient, of course. So it's also a commercial angle. So there are some companies specialized in all these antioxidants and healthy food for IVF people. So, like I say, if there would be something magical again, we would, yeah, we would be obligated to mention it to patients and, yeah, really give the advice of eating some kinds of food or some supplements in their food to increase their pregnancy chances. But yeah, as far as I know, and I know literature and the world of ART quite well, there is no magic thing. Of course, there are some things that are very detrimental for the egg or sperm quality, like smoking. Smoking will reduce 50% of your pregnancy chance, both in, especially in female, but also in male. Too much alcohol will also decrease your sperm quality and your egg quality. So that's our obvious things that we know that are reducing your success rates immensely. But apart from smoking and drinking, I would not say there are there is concrete evidence that there is something magic that can improve your fertility. Of course, yeah, your lifestyle. Well, the BMI is also important. Yeah, that also affects your success rate. So yeah, that's why we have these programs also for patients that they keep up a healthy lifestyle, but that's more to reduce the BMI, for example, because we know that the BMI will affect your chance of pregnancy. But as far as of these antioxidants and so on, there are no magic supplements that we would recommend, except, yeah, not using too much alcohol and smoking. That's very bad for if you want to get pregnant.
And wonderful. Once again, of course, thank you so much for your opinion and thank you for sharing everything with us tonight. It was definitely interesting. And thank you all for joining us tonight for your questions and indeed for staying. And I do hope and I do believe it was quite useful and interesting for you. And well, thank you so much for joining us as well, Dr. Bjorn. It has been a pleasure to have you and I hope you also enjoyed this. And well, before I let you go, anything else you would like to add?
No, it was a pleasure to participate in this, and I think it's really, yeah, it's a really good initiative to have these webinars, especially for patients. And it's also something that we will start also in our center soon, because yeah, we know, yeah, well, it's sometimes a pity that patients don't know about all the techniques, and even, yeah, experts, even experts in the field sometimes do not know that this assisted oocyte activation exists, and sometimes they refer couples to oocyte donation or sperm donation, and it's a pity that they don't have a chance then to their own genetic child. So yeah, we have to inform the patients and we have to let them aware that these techniques are available and they still have a chance for their own genetic child. So that's why it's good to have these initiatives to talk with patients and to discuss topics with patients. So I wish you good luck with all the webinars that you're organizing, Caroline.
Thank you. Thank you so much indeed. It's definitely important for us as well to be able to help you out as much as we can. So thank you for attending all those webinars. And as you know, tonight we do have another webinar at 8 p.m. UK time. So I do hope you will be able to join us as well. And once again, Dr. Björn, it has been a pleasure. And well, I just want to mention this has been recorded. So anyone, if you would like to simply have a look at the presentation and the Q&A session afterwards, it will be available on our website, myivfanswers.com, but also on our YouTube channel. So, well, go ahead and check it out. There are some more webinars, past webinars on our website as well. And, well, again, thank you. Have a lovely afternoon. And I do hope that we will have a chance to simply have another webinar with you.
Okay, I
Wonderful.
enjoyed it. Bye
Thank you so
bye.
much. Take care. Bye.
Bye.